And now, again, for the skeptics in the audience, last but not least, does it work? Jeff Alexander. Thank you.
Good afternoon, everyone. You just heard Chris and Lee doing a deep dive on issues related to the collective psychology of primary care practices as they consider moving into the patient-centered medical home model. I'm going to be taking a very different approach in terms of my discussion of the research. It's a 35,000 feet view of the research literature in this area, and specifically with an eye to trying to answer the question of what is it telling us about whether or not PCMH works. Big question. And specifically, I think what I want to spend my time on is really trying to assess what does the research literature say about what aspects of patient outcomes are affected by PCMH. Is it access? Is it quality? Is it patient satisfaction? Is it outcomes in other areas? And the second area I want to cover is, well, can we believe these results? You know, are they credible? Can you take them and run with them, if you will? And finally, I want to offer sort of a modest proposal as to how we can advance research in this area and where research fits in the larger scheme of advancing primary care and patient-centered medical home models in this country. So what's the background here? Let me start by saying that there's a lot to love about PCMH. I mean, who doesn't like improving quality, patient-centered care, data-driven decisions, improved or extended access, et cetera, et cetera. Intuitively, this resonates to a lot of people, but I would submit that this is not the same as an evidentiary base to suggest that this model works. So it's okay to continue to love PCMH, but you should temper that love to some extent and engage in tough love by saying, well, where is the evidence to support my affection for this particular model of care? Very practically speaking, and we've picked this up in our own research when we go out and talk to physicians in practices, they're saying, well, yeah, this intuitively makes sense, and we kind of believe in the value proposition of PCMH, but show us the evidence, and particularly on physicians' side. Physicians tend to be very data-driven. They want to see the evidence as to whether or not it works. So it's not an unreasonable question to ask. And finally, I think we're at the point, as far as this line of inquiry, where we have the beginnings of a critical mass of evidence to allow us to say something about whether or not PCMH works. Now, it's important to note here that we're not all the way there. This is a very early, we're in very early stages of inquiry into this model, so we've got a lot of additional work to do, but I think we are in a position to say several things about the question. So when we ask the question, does PCMH work, you can kind of parse this out in several different ways. The first is, well, can it work? And the way I sort of look at this is kind of the efficacy question. Is there an association or relationship between the PCMH model and outcomes of interest, particularly as they pertain to patients and their health and well-being? Second question is, will it work? And this pertains more to, well, what are the conditions under which, in the real world, this is going to have an effect? Will it affect all patients? Is it suitable for all practices? Okay, this is, again, the effectiveness question. Third question is is it worth it? Okay, we can demonstrate that there's a relationship between PCMH and patient-related outcomes, but it may come at a cost that is prohibitive. So this is the question of, does PCMH provide value? And finally, how can we put it into practice? This is the issue that Chris was addressing in his talk. Just because it works, just because we think it's a good idea, just because we love it, doesn't mean it's going to be easy to implement. So there's a lot of work that needs to be done on the implementation side. So how do we approach this question of does PCMH work? Our approach was to really try to do a comprehensive and systematic review of the research literature in this area. And whenever you do a review of the literature in this area, there's always a set of inclusion criteria and a set of exclusion criteria. So I'm just going to go over these very briefly just so you know what the parameters of this work were. We tended to focus on peer-reviewed empirical research articles that treated PCMH as a comprehensive system of care. We also wanted to focus on those articles that included that first criterion and which looked at the model in relation to some set of patient-related outcomes. So this means that we didn't look at articles that only considered, say, care coordination, okay, or that looked at HIT in relation to patient outcomes. We didn't look at articles that examined implementation of PCMH, although that's a very important topic. It didn't fall within the parameters of our research. So what we found on the basis of this literature review was that actually there were relatively few studies that took this kind of holistic approach in which patient-related outcomes were assessed. And we found exactly 49 articles. Not a huge amount of studies, a huge number of studies, but enough, I think, to give us at least a preliminary picture of where the literature is headed and where it should be headed in the future. So when we sorted all these articles out, what we found was that they tended to kind of group into 5 areas, and these were sorted by the outcomes that they looked at. The first was access, service utilization, patient satisfaction and quality, studies that considered multiple outcomes related to patients, and I'll explain what that means in just a second, and studies that related to the cost of care. So what I'm going to do is briefly go through each of these to give you a snapshot sense of what we discovered by or through this review of the literature. So access studies. The rationale for these studies should be fairly clear, and that is if PCMH is to improve healthcare processes and outcomes, individuals must first have regular and sustained access to a medical home and a regular provider. Okay? Most of the studies that we found in this area tended to focus on what I call special populations: children with special needs, underrepresented minorities, et cetera, et cetera. The results of the studies, just to sum up, were not encouraging, particularly with respect to these special populations. Many of the studies suggested that access for these special groups was relatively limited compared to the general population, particularly when it came to children and underrepresented minorities, and that there were certain combinations of risk factors that limited access to medical homes, typically income, race and ethnicity, and there were several others. So moving on to service utilization. So PCMH is designed to increase the use of appropriate services and decrease the use of inappropriate services through improved access and coordination of care by a primary care provider, one of the basic tenets of the model. We actually found 18 empirical studies in this area that address service utilization, and by and large, the results were pretty positive in favor of the PCMH model. In fact, all but 3 studies indicated either greater use of appropriate care or services, which typically were operationalized as primary care visits, immunization rates, things of that nature, and decreased use of inappropriate services, which were primarily operationalized as emergency department visits, readmissions to hospitals, and things of that ilk. The two exceptions, I think, were in the area of immunization rates. I think there were several studies that found no difference between PCMH and non-PCMH patients in terms of immunization rates. Let's move on to patient satisfaction and quality. The PCMH model is designed to improve patient satisfaction and quality by providing patient-centered care that focuses on individual health goals and needs. And to the extent that these tenets are met, patients should feel satisfied with their care and with the quality of the care experience. We found 6 studies that kind of looked at this set of outcomes in our search. And what we found in general was that patients tended to be quite satisfied with the care they received under PCMH relative to patients receiving care under other care models. There were exceptions, however, and they tended to relate to coordination of referrals, connection with outside resources, wait times, and to a certain extent, cultural sensitivity. Several studies, 8 to be exact, focused on outcomes that spanned the areas I'd mentioned. Typically these studies looked at patient satisfaction as one of the outcomes, but also considered other outcomes related to kind of HEDIS-related quality measures, service utilization, measures of access, et cetera, et cetera. And the rationale behind this group of studies is that PCMH was viewed to be a kind of a holistic model of care that treated the whole patient throughout the life course. And as a result, the investigators in this area viewed looking at only one outcome as sort of inappropriate. You really need to look at a broad spectrum of outcomes that reflect that whole person. The study findings in this area indicate that patients' PCMH is associated with higher or improved outcomes compared to non-PCMH comparison group. These are a pretty strong set of findings. And just parenthetically, the study designs in these areas were typically much stronger than they were in the other areas I mentioned. They tended to employ either experimental or quasi-experimental designs, which probably adds a bit to the credibility of the findings in this area. And finally, I just want to mention that typically these studies found improvements in more than one area related to patient outcomes. So it wasn't just in satisfaction with care, it also was in access or quality, things of that ilk. And then bringing up the rear, unfortunately, we only have 2 studies that I found related to cost. One related to the cost savings that result from reduced emergency department visits, and the other focusing on outpatient cost. And that study was actually a little bit unusual because the investigators had a hard time interpreting the results. The findings suggested that actually outpatient costs went up for PCMH patients relative to non-PCMH patients, but the explanations were a little convoluted. On the one hand, for example, the investigators suggested that, well, increased outpatient costs is a reflection of a greater use of primary care services, but on the other hand, it might reflect poor coordination of care, and therefore costs would increase. So clearly, the jury is still out on the cost side, and much more work needs to be done. All right. So how do we summarize this fairly modest body of research, at least up to this point? I think it's fair to say that there's considerable support for appropriate service utilization and patient satisfaction. It comes across pretty strongly in our review. Somewhat more mixed support for cost savings and higher quality of care, and then weak support for PCMH access, particularly by special populations. So the bottom line here, at least so far, and in our own humble opinion, is that the preliminary research evidence is encouraging, but it may be too early to declare victory. And so I want to spend the rest of my time talking about what I mean by that. And I want to focus first on some of the aspects of these studies that I think bear further scrutiny and which may sort of color your acceptance or lack of acceptance of these findings. And I group them into kind of four areas. One is sample and external validity issues. The second is measurement issues. Third is research design issues. And then the fourth is kind of a big question, and that is, are we asking the right questions? So let's tackle the first one, sample and external validity issues. As others have mentioned today, a lot of the early work that's been done in this area has been conducted on small demonstration projects, either that or very large surveys of individual patients. So you have this kind of bimodal distribution of very small samples of physician practices and another set of studies that focuses not on practices at all, but exclusively on patients. In general, I think it's probably safe to say that in either case that these samples are not representative of either practices that are likely to be involved in PCMH or of the patients treated under this model of care. And finally, and importantly, none of these studies, either of patients or of practices, take into consideration the context in which PCMH operates. So we heard this morning about the medical neighborhood. We heard this morning this afternoon about care coordination with other providers, access or referrals to behavioral health. None of these really have been appropriately considered in the studies that have been done so far. So clearly, this is a deficit in the research that needs to be further explored and expanded. Let me turn to the measurement issues in PCMH. This is really a big one in my view. I'd say maybe in a third of the studies we reviewed, PCMH is not really measured at all. It's sort of assumed to exist, but not measured in any direct fashion. And in other cases, PCMH is measured by the patient's perceptions of exposure to aspects of care related to PCMH. And clearly, I'm a great believer that the patient's perspective is important here, but I would also submit that patients are typically not in the ideal position to kind of assess all aspects of the PCMH model. So again, this might be considered sort of a measurement limitation. Significant limitations or significant variation in terms of how PCMH is defined and operationalized. And let me just give you one quick example here. Care coordination. For those studies that did consider care coordination as an aspect of the research, the measures range from adequate communication among providers, receipt of assistance in coordinating care, assistance interpreting laboratory results, use of chronic condition management care plans, family participation in community-based resources. So we're all over the map in terms of how care coordination is measured and operationalized in these studies. And finally, the measures tend to be, in my view, sort of linear and additive. In other words, if you have more PCMH components, you're doing better, or your PCMH score is higher. What these measures don't do, however, is assess the systemic properties of PCMH, and we're just not quite there in terms of our measurement development. But if you really believe that PCMH is a system of care, I would submit to you that relatively few of the existing measures really capture that systemic nature. Research design issues. This is a little bit related to my previous point. There's relatively little assessment of the synergistic effect of components of the PCMH model. A lot of the better studies consider multiple components of PCMH, but they look at the sort of the independent effects of those components as opposed to how they operate interactively to affect care. And again, I think this is sort of a limitation of the designs of some of these studies. Selection bias. Lee was referring to this earlier when he talked about the National Demonstration Project. Often in PCMH research and in quality improvement research in general, you have the folks participating that were predisposed to do well and to really engage in these models, not necessarily reflective of the population, in this case of primary practices that might adopt or take on this model. A lot of PCMH studies are cross-sectional. I mean, this is a kind of a no-brainer. You have endogeneity problems, and you really can't assess change in patient outcomes as a result of a change in the practice style of a primary care practice, for example. Short study duration. This is really important because, and I'm speaking as kind of an organizational researcher here, changes in organizations tend to undergo entropy. They tend to kind of revert to previous states unless they're really institutionalized. And a lot of the PCMH studies out there really haven't been conducted over long periods to assess whether or not that happens. So again, there's a bit of a deficit there. And finally, there's a unit of analysis issue, and I really don't know the answer to this. As I said, some of the units of analysis that have been examined ranged from the individual patient to the physician practice to the healthcare system, and I'm not really sure what the appropriate unit of analysis should be here. If you believe PCMH is a system of care, it should probably extend beyond either the individual patient or the individual primary care practitioner. But how that system of care is actually captured in a measurement sense, I think we still need to do more work on. All right, and I only have one more slide here, but I want to try to sort of put this into perspective. And you know, as I looked at these slides last night, I said, "Boy, this is kind of a downer." You know, all this, you know, how much can we really learn from this? And I just want to say that, you know, this is not at all unusual. The issues I mentioned are not unusual at all for a field in relatively early stages of development. And the purpose in my sort of being critical in my remarks is not to say, well, we shouldn't pay attention to this. Really just the opposite. It's to sort of raise some red flags, but primarily for the purpose of how can we kind of extend and improve this research. You know, PCMH research it's like quality improvement. You know, we kind of note problems and we attempt to improve on those problems. And I see this field of inquiry as being no different than that. So I think we have a solid foundation which to start. We have some preliminary findings that I think are supportive and suggestive that PCMH works. It's not a panacea, and we have much more work to be done. Where does all this fit, and where does science fit in our kind of journey toward PCMH? And this is my little diagram to try to describe that. We need to keep doing the science. We need to keep pushing the research forward. I mentioned a lot of issues. There's more work to be done not only on the efficacy side, but on the effectiveness side, clearly on the implementation side, as Chris and Lee pointed out. But there also needs to go hand in hand with that is sort of attention to delivery capacity. And David mentioned a lot of this in his remarks. I think they're really kind of spot on. And they refer to things like not only HIT, but also providing support for change management in these practices, leadership from healthcare systems and from healthcare insurers, providing forums for information exchange and learning. All this is part and parcel to providing infrastructure. And then the final component is let's create a market for PCMH. And by that I mean let's align the incentives. Let's provide appropriate levels of reimbursement for practices engaged in this in this model. And finally, and I don't think everyone has really mentioned this directly, we need to engage patients more as consumers or drivers of this market. And this is a very hard nut to crack, but we're doing work on this under the Aligning Forces for Quality project. And if consumers are informed, if they know what to look for, they can really help kind of drive practices toward the PCMH models in ways that I think will really result in some positive outcomes, both for the practices and for the patients themselves. So, conclude on that note.
That's great. Thanks. Thank you so much, Jeff. That really was a compelling piece of review of the literature, and I think really important for us all to understand